So today it will be the 9th lecture, Maxillofacial cases. We have two guest lecturers, Martin Bengtsson and Per Derand, Department of Oral and Maxillofacial Surgery, Skåne University Hospital. Same conflicts as each previous lecture. So the outline of today will be that first Martin will show two cases. They will take questions and answers for that part, and then Per will show another two cases, and then questions and answers. And if time permits, I will do live segmentation of case 4. And then in the end, some questions and answers. So as usual, please type the questions in the chat window during the lectures, and Philip will moderate them. So with that, I will hand over to Martin.
Thank you very much. Thank you for the introduction, Einar. I'm pleased to be a part of this course on 3D printing. And today we're going to show a few cases from the maxillofacial surgery department. And it will be, as Einar told me and my colleague Per Derand, that have divided this lecture into two parts. Before we start, I want to show you area of maxillofacial surgery covers a few therapies and diagnoses, and today we are going to show you 4 of them. And for my part, it's orthognathic surgery, reconstruction, trauma is Per Derand, and printed titanium is also Per Derand. I would like to focus on the part that 3D printing is helping us in our facility and helping the patients. So there is a lot more to say about these patients and treatment methods that we will not cover today. Firstly, the dentofacial deformities is a condition that need the treatment of orthognathic surgery. Orthognathic surgery is a treatment that covers both dentition, bite, and the facial appearance. The patients are having a treatment need because they have severe problems with biting or chewing, as you can see in the upper row here. And you can also see that the patients shown here have aesthetical disabilities with a facial appearance not looking normal at all. So the treatment needs are both functional and aesthetic. We always do the treatment in collaboration with a specialist dentist in orthodontics, and the treatment take about 2 years to perform in total. Firstly, the diagnosis we facilitate from 3D printing from a CT scan. As you can see in this picture, it's a patient suffering from a condition called hemifacial microsomia. And as you can see, there is a severe asymmetric appearance, and it is affected on the left side. This is, of course, a CT scan, so it does not show any soft tissues at all. Another example is here, that is a patient with a condition called fibrous dysplasia, and this is the patient's right side that is affected. It's good to have physical models to look at and discuss around when we are planning these patients. So it helps us a lot. This technique is not new. We have used it for almost 20 years, but former we used external service centers, but today with the department with 3D printing at the hospital, we can do it more rapidly, and that is of course good for the patients. When we plan the patient, we have software programs combining several 3D techniques. And as you can see examples of here, we have the CT scan on the left. In the middle, we have a 3D photography. And on the right, we have a 3D model of the bite and the teeth. The reason why we want to have the bite and the teeth as a separate recording is that the detail is not very high defined in the CT scan, so we need a more higher resolution in the dentition. These recordings we can merge together in a software program, as you can see here in the next picture, and we can plan it in 3D. We can segmentize and move the bony parts of the images and perform the treatment digitally before we do it in the patients. In the next picture, you can see here a simulation of the treatment. That's a patient with a severe asymmetric appearance, and we can see the movements going from previous to planned operation. We'll show it again for you here. So this is the simulation, and you can see the planning was done in the CT recording, and the simulation is done in the 3D photography. Then when we have planned the patient, we move further on to surgery, and we need to have a technique that transfers the planning to the surgery. And today we have two examples of modern technique helping us with that transference. Firstly, navigation, and that is quite expensive equipment to have at the department. And on the other hand, the technique is not that current up to now compared to the other technique, that is surgical indexes. So we use surgical indexes today in our department, and that we have done for the last 35 years. I will show you how we did before, and I will also show you how we do it with more modern technique and 3D printing. So here in the upper row, you can see the planning on the 3D models from the CT scan. And in the lower row, you can see at the left the surgical index. You can see in the middle the design of the surgical index digitally in the computer. And on the right, you can see how it was done previously when we did it manually without computer aiding. And here are some more pictures about the traditional way of producing these indexes. It was done on plaster of Paris models and manually in a lab without any computer aiding at all. This is very high accuracy and reliability on these indexes. So moving into the digital world and the 3D printing world have actually not made the accuracy better, but it has made it more simple for us to do it. And of course, the digital planning is an advantage compared to before computers. So today we do the planning, as you can see in the upper row. We do the design of the surgical index, and that is on the left, on the right in the upper row. And then in the lower row, you have the extracted design sent for 3D printing, and in lower row to the right, you have the printed surgical index. In this next picture, you can see a patient having treatment with orthognathic surgery. You can see the photography before treatment to the left. Then we have the indexes that help us doing the movement, and then you have the outcome on the right. As you can see, the patient is having quite an extensive change in the facial appearance, and all movements performed during surgery is depending on this little plastic surgical index. So it's very important that this device functioning well with as close to 100% accuracy as possible. So it is important that when we do it, we have a high quality of both planning and production of the index. And to see how the outcome was in this patient, you can see here from a frontal view, the simulation in the upper row and the real photographies in the lower row. You can see in the left column preoperatively, and you can see in the right column how it was from the outcome of surgery at the lower and how it was from the outcome of simulation at the upper. So you can compare how they correspond to each other. And in the next picture, we will see from a lateral view on this patient that we saw before. And here you can compare how the pictures correspond to each other. We have to the left, the original photography. We have the surgical computerized simulation in the middle. And then you have to the right, the outcome 1 year after surgery. So that was all for orthognathic surgery then. We have looked at how we use 3D printing technique, both in diagnostic purposes, in planning, and in surgery. Then we move further to the next group of patients, and that I have called reconstruction. During this part of the lecture, I will show you a few pictures from the surgical department, and for those of you that are not used to see this picture and perhaps sensible to them, I suggest you turn off your screen now and keep on listening to me. And I will tell you again when these pictures are shown, so you can turn on your screen again. So reconstruction is needed when we are missing a part of the body. And in the next picture, you can see here that we have a problem in this patient. We have been forced to take out the lower jaw, and that is because of a tumor in this case. You can see on the right side an osteosarcoma. We can also have other reasons for taking out tissues, and that could be necrosis of the tissue, that is death of the tissue, and we can also have trauma as a cause, and sometimes we have shotgun traumas, for example, that takes away a lot of the tissues. So then we need to reconstruct, and our golden standard reconstruction method is to take tissues from other parts of the patient's body. And for having bony reconstruction, we can take from the lower leg, that's the fibula. We can take from the hip, that's the DCIA. We can take from the forearm, and that's the radial. And we can take from a bone connected to the shoulder, and that's the scapula. We choose the harvesting region depending on what we want to achieve when we reconstruct. Traditionally, we have used standardized models and cutting guides, as you can see here, and it corresponds quite well to the anatomy. Today, we also have the possibilities through 3D printing to make the surgery customized, and I will show you this now. Firstly, as in the orthognathic surgery cases, we can, of course, print the CT scan and plan the operation, and this is a tumor affecting the lower jaw. We cannot see the tumor because it's soft tissue, and that does not show in the CT scan, but we can see how the tumor affects the lower jaw. We also use the CT scan to plan the surgery in the computer software, as you can see here. And now we have done the resection of the tumor. We have put in a model of a fibula, that's the lower leg bone, and we have cutting it into 3 pieces, having a simulation of the original anatomy as close as possible. Then we can also print the plan, as you can see here in the transparent model. And we can also print out a cutting guide that helps us to perform the angulations of the cutting in the bone correctly. Here you can see a comparison between the standardized traditional cutting guide and the customized printed cutting guide. So we have the tumor here exposed, and you can see it now for real and how it affects the bone on the model. We take out with the margins. We always do that when we have a tumor to be sure that we have taken out everything. Then we have the defect in the mandible, and I am showing you here the planning, and you can see how it corresponds quite well to the defect of the lower jaw. We have taken out a fibula, and here we do it together with both ENT surgeons and plastic surgeons. As you can see, we have not only taking out the fibula bone, the lower leg bone, or we have taken out also muscle and vessel, because we need to connect vessels in the bone transplant to the neck vessels to have a blood supply for the transplant that helps it to heal up well. We have also put in the cutting guide, and that helps us to perform cutting according to the planning. Then we have connected the lower leg bone piece to the defect of the lower jaw with titanium plates, as you can see here. And you can also see that this is a dark-skinned patient, so you can see the skin paddle in the floor of the mouth beneath the tongue. So for those that have turned off your screens, you can put on them again, because I will not show any more surgery pictures. So now we look at the X-ray, and you can see here on this patient that the anatomy and the reconstruction corresponds quite well to the other facial structures, both from the lateral view and from the frontal view. And so this was my cases for today. And now I think we have a little time for questions, if we have any. How is it, Philip? Did you have any questions for me for now?
There hasn't come any questions yet, but I have a question.
Yes.
How much from like the fibula do you take? Do you take out the whole bone, or do you take out part of the bone, or how do you work?
Yes, thank you. That was an appropriate question, because the fibula is of course needed in the lower leg as well. So we cannot take out the whole part of it. We know that there are muscles connected to the fibula, and there are muscles both in the knee region and in the ankle region. And it's enough to leave a little piece of the fibula in both these areas. And we used to leave at least 80 millimeters in each end of the fibula, not affecting the muscle attachment. So we can take out the rest, and that we often do. So we take all the bone that we can, and after reconstruction, we often have put away some of the bone that we do not need, but we always take out as much as possible. So I hope that was an answer for your question.
Absolutely.
Thank you. If there are any further questions arising, I'm sure we have time for them after the lecture. So I now am pleased to leave the microphone and
we actually have some questions if you want to take them now, or do you want to take them later?
Yeah, shoot. I'm ready for them, so please.
Yes. When you take the fibula out, how is it recovered later? Do surgeons replace an implant there?
No, that is not needed. We can take both muscle and bone and skin paddle. Of course, the patients have a period of wound healing after that. But after a few weeks, the patients are healthy enough to do even sport activities. Of course, elderly patients take a bit longer to heal up compared to younger patients, but we have examples of football players that are on the football plan again after just a few months.
Interesting. There was also a question from Petter and Mini. How do muscles reattach to the reconstructed jaw?
Thank you. That's a good question. Of course, we try to have the periosteum. That's the tissue that helps growing bone. We try to save that, and the periosteum is connected to the muscle. So we connect the periosteum to the bone transplant, and then we have automatically a connection of the muscle to that tissue. So that the biology and the healing process helps us there. If we do not have periosteum, we can suture the muscles to the bone, and that helps the biology and the healing process to connect the muscles to the bone. Okay.
Great. I think that if you have any more questions for Magnus, you could, or Martin, you can post them in the chat, and you can write who you want to ask the question to.
Thank you very much. So I leave the screen here and leave over to my colleague Per Derand. Thank you very much.
Hello everybody, my name is Per Derand and I also work as a consultant at the Department of Oral and Maxillofacial Surgery here in Lund. I'm proud to be able to show you these two cases. The first one being a PSI patient, and PSI stands for patient-specific implant, and the second one being a trauma case. As you can see, there are a lot of names in this slide, and we have a close collaboration in this type of patient with the ENT department. Just going to have a laser pointer here. The first patient gave me over the phone his approval of consent verbally, and so I have the ability to show his medical record and also clinical photos. Hemangioma is a benign tumor, and it can be presented in all over our region in the mouth, preferably in the lower lip or under the tongue. If the tumor is growing inside the bone, it's preferably in the cheekbone, or the bone we call os zygomatikus in Latin. It's asymptomatic in most cases, and the treatment for this type of tumor is surgical resection with no marginal needed. The complication in this type of surgery is of course bleeding, and in this case the risk of damaging sensory nerve, in this case below the eye. The patient in this case was 67 years old, and prior to this event he had a heart attack a couple of years ago. Otherwise he was perfectly healthy. He had first noted a lump growing slowly beneath the right eye, and he had no symptoms at all. He was referred to our department in November 2018. The sensory nerve below the right eye was fully functional. A CT scan was conducted, and in this image you can see a spherical growth pattern in the right cheekbone. And in the frontal view they have the eye socket rim, and below the right eye you could see this spherical growth pattern. A 3D reconstruction of the CT scans, it's much clearer to see this anomaly on the right side. As mentioned before, we have in our department a 3D camera called 3DMD, and this patient I photographed, the left photograph is taken November 2018. The middle picture is taken prior to surgery, May 2020, and the most right photo is postoperative. One can rotate this image, and if you look closely, you can see that from November 2018 to prior to surgery, this lump has grown a little bit. So in this the time before surgery, he had a pressurized feeling to the right eye, so it was quite urgent to get this surgery done. The aim of this treatment, of course, remove the tumor in one piece and do a reconstruction at the same time. We used biocompatible material, and this was titanium alloy, laser sintered by a company in Belgium called Materialize. So I contacted them and got hooked up with one of their technicians, and this is the start of the virtual treatment plan. This is the CT construction, and as you can see, the big lump under the right eye socket. We do virtual surgical resection and remove this red lump, and the technician mirrored the healthy left side over to the right side to be able to have this as a template during the computer-aided design. Here you see the final result of this design. I will point out that the resection line here is very close to this hole, and this hole, here comes the nerve for the skin beneath the lower eye, below the right eye. We also ordered a cutting guide because there was a very close distance between the nerve and the tumor. So the final result with screws, and you also get a chart telling you exactly how long the screws should be in a certain position. Prior to surgery, we did an angiography, and this is performed properly, so we can see if there is any major vessel in the area. And in this case, there were no major vessels, so we didn't have the need for endovascular embolization. I'm going now to show you some pictures from the operation, and if you are not want to see them, you have to turn off your screen now, and I will tell you later when you can put the screen on again. To be able to remove this tumor, we have to do 3 entrances. You do 1 entrance up in the upper lid, and 1 in the lower lid, and 1 incision inside the mouth. I will show that incision later on. This is the picture taken from above the patient. You have the mouth in this area here for orientation, and this is the right nose, and the eye is up here, so this is the lower lid incision, and this is the tumor. Further dissection, the lump presents itself like this. It's hard on the surface, so it's easy to dissect this. Here we remove the blue tumor, and this is the eye socket, and this is the sinus in the upper jaw. This is the front view, and this is the back view. We take our titanium printed mesh, and it looks like this, and on the inside, so it's just the outline of the sagoma or the cheekbone. We inserted it into the patient through the incision in the mouth, and it looks like this at the lower lid incision. This is the incision in the mouth. The patient's teeth are here, the nose, and you have a quite good view of the implant this way. The patient forced me to take a picture of him after the surgery. We had some bleeding and he wanted that picture. So it's better to bleed out than have a bleeding into the eye. So this is not very severe. Post-operatively, we took a CT scan and you can see the titanium mesh is quite good. The fitting is quite good. This is the inside and this is from the right side. Professor Ann Hermansson mailed me this photo 3 weeks post-surgery, and you can see that the swelling is going down, and he had a reduced double vision and, sorry to say, loss of sensation in the skin below the right eye. So is there any question?
Thank you, Per. There hasn't come any questions right now, but we could wait a few minutes to just see if there comes any questions.
Otherwise, I can go on with the next case, and we take the question later.
Yeah, we can do so. There was actually a question from Anders. How did you apply the cutting guide over the tumor?
The cutting guide was well, it's only have one fit. The cutting guide is we held it with our finger because it had only one place you can put the cutting guide. It's a very high precision, so one fit all. It fitted only in one place, so you can't move it around. It's like glued to one place, so it's very easy.
Yes, and there is a question from Vasilis. Is there a reason you chose titanium instead of PEEK?
Yes, there is. I have no personal experience with PEEK and titanium. We have a vast majority of experience through our dental implants, and so titanium is a well-known biocompatible material to use. So that's why I used it. But I'm not an enemy of PEEK, but we chose this material.
Thank you. There are no more questions right now, so maybe you could continue and we see if there pops up any more questions during your next case.
Okay. So our next case is a trauma case, and as you can see, there are even more names on this slide. We have also, in this case, collaboration with the Department of Neurosurgery, because this is a level 1 trauma center we work at. So this patient had also brain injuries. The patient was a 39-year-old patient, and he had diabetes type 1, but otherwise he was perfectly healthy prior to the accident. He fell at home from a flight of stairs and didn't mind, so he didn't sought any medical care for 1 week. So there is a patient delay in this case. We were called on the Friday, and he was transferred from the hospital of Ljungby the 17th of May. He had, as I mentioned, minor symptoms and minor headache. The CT scan showed injuries to the facial skeleton and the frontal cranial base. This is a reconstruction. As you can see, the The chin bone has a bigger offset than normal. The nose is also wider than normal, and the frontal bone is also rotated up here. The frontal bone is rotated 90 degrees inwards, and the arch, the chin bone arch, is also fractured just above the lower jaw joint. This is a picture of the cranial base, and you can see this roof of the eye socket is pointing 90 degrees into the brain. So the goals for this reconstruction is of course to symmetrically reconstruct the facial bone and also reduce the operation time. So we turned to 3D printing and extracted the CT scans from the PACS system. And for you who don't know what PACS stands for, it stands for Patient Archive Communication System, which is a database for medical imaging. We virtually mirrored the unaffected side to the damaged side and 3D printed this mirrored skeleton. We also use this mold or template to bend the titanium plates during the surgery. I will show you how I did this. This is the reconstructed CT scan with a trauma injury to the left side. I made a cutting plane using cephalometric landmarks, in this case Nasion and Sella and Basion, for those who know where they lie. Cut the model in half and threw the pink model away. I mirrored the yellow one over to the right side, and it looked like this. To calibrate this position, I re-imported the model into the CT scan, and you can see it's lined out here quite symmetrically. So here we have the trauma case on the left photo and our template on the right side. So I forced Erik Ekblom to print this on a Saturday, and I forced also Einar to go to take this 3D printed model to the sterilization department on the Sunday, because the operation was on a Monday. The next slide I'm going to show you is a slide for operation, so if you want to turn your screens off, you do that now. This is a slide where we do some alternate haircut for the patient, and we do an incision from the left ear over the head over to the other side. Then we can fold the skin forward and expose the fracture bone up here. So this is the bone, and this is skin, and then you have the left eye up here. While our resident and ENT surgeon were dissecting and unfolding the cheekbone, I have the ability to pre-bend the titanium plates, and by that saving time during the operation. It's very difficult to bend them at freehand, and it never looks good on the CT scan postoperatively. Now you can look again with your screens on, and I think this 3-image summarized this operation quite well. You can see on this left photo we got the eye sockets that are very symmetrical. We got the middle photo, and we got the arch symmetrically to the healthy side on this side, and we also can check the bite of the patient that it's aligned. 2 days postoperatively, the wound looks like this, and the Band-Aid, you can see, go from the left side to the right side. And if there was any question regarding that case, I'd be happy to answer them.
Yes, thank you. There are no questions right now. Let's wait to see if there will pop up any.
I can ask a question to both of you. We discussed it before, but I think it's general interest. So, can you describe it more? What's the reason you want to have the patient's own bone in the mandible reconstructions rather than having patient-specific implants for different materials?
You can repeat the question. And,
yeah. So. So, Martin, so I think it's...
Here again, yeah.
Yep.
I didn't hear the question because I was without headphones.
So, we discussed it before, but I think it's of general interest for all in the course, that if you can describe a bit, what's the reason why you want to have patient's own bone from the fibula or so in the mandible compared to having patient-specific implants?
Yeah, yes, that's a good question. In healthy patients without, and now we are talking about tumor cases, especially, they always have, or often have, most often have a combination of surgery and radiotherapy. And when you give a patient radiotherapy, you decrease the blood supply to all the tissues around the tumor. So if you put in as patient-specific implant in this environment, it's very prone to get infected. So we want to have blood supplied tissue from an area that wasn't exposed to the radiation to have a good defense against infections locally. So that's the main reason why using vascularized free tissue transfers. I hope that was an answer.
Yeah, thank you. Philip, do you have more things on the chat?
Yeah, there's a question to Per instead.
I changed the headphones again. Here it comes through.
Okay, you can repeat the question.
There's a question from Hannah. The titanium plates you use for reconstruction, how many different sizes do you have to work with?
How many different
sizes?
This is patient-specific implant, so it's done for this patient only. There is no sizes.
I think she's asking about the one where you bent the titanium.
The last case?
I think so.
Sizes of what?
The one exactly. You talked about bending a plate.
Yes, I used the 3D. We can go back. I used this 3D printed. This is sterilized, so I can use it directly on the patient on the OR room. So I bend. This is the mirrored, healthy right side. Mirrored over to the left side, so I can bend the plates directly to on this skull. So it's quite handy to do.
Okay, so she's asking about, do you have different sizes of these plates, or do you?
Yes,
have,
we do, and in this case we used 2.0. I think it's from Materialize. Yes. You can have 1.3, 1.5, 2.0. There are different sizes for different places. This particular bone that's on the arc is a load-bearing arc, so you need a little bigger plate in this area.
Great, thank you. Do we have any more questions in the chat?
I have a question. My name is Maurice, and Can you tell us how much time do you save by using 3D printed model to when you are bending your implants?
Yes, I can. We have measured that earlier, and about 20 minutes you can reduce the operation time.
Okay, thank you.
Hannah has a question. How long
Yes.
is the total operation time?
In this case, I thought it was 5 hours. And in the other case, the PSI case, it was 3.5 hour operation time.
If there are no more questions, I think we will thank Per for his cases.
Yes, thank you.
So now I will do the same case as Per did, the trauma case. So start with loading the case. Okay, go to the 3D printing tab. So the first thing I will do is sort of try to straighten it up. It's not completely straight. And I need to resample to isotropic. So all voxels are the same, different distance in all the directions. So we rotate a bit right, something like this. Slightly more, get this straight. Rotate that. I can see on the coronal view, and it's not super important to get it completely right, but it just helps the segmentation. Okay, so the first thing is I will do a threshold, so I will adjust the threshold. So something like this is maybe good for the bones. Okay, and we can see get a lot of noise here, so I take only the remove all the smaller parts, get a lot of the noise away. Can look at it in 3D, and we clearly see here there's a lot of dental artifact. So we can just click on it and see it. Now I'll switch to the only transversal view, so get a bit more zoomed in. And one trick we can do to remove these dental artifacts is we can set threshold a bit more aggressive, and then we can do local thresholding in this area. So now do local thresholding only here in the dental area. And when doing this, it's important to ensure that we are in 3D mode, so we apply this threshold in a sphere here. Okay, that's one end. You can see it's not going to solve the problem entirely, but it will help a lot. Okay. So go back, and now I'll use the eraser to really work on this. Something like this. Sometimes it helps if I put the contours on. It's easy for me to see. Up again. Here we have some nasty artifacts, and dental artifacts are sometimes quite painful to remove. And it depends on the application if it's important or not to get it completely perfect. In this application it's not super critical. So, and now we can remove small non-contiguous parts. So we can check how this looks in 3D. And we got away most of it. Maybe it's a slight thing here that I want to delete, but otherwise it's okay. So that was that part. Now we can smooth the object. Okay, so maybe. Well, before we that, what I do something else. I would like to fill the bones so it's so you don't have any voids when printing. Take away these contours. So one effective way of doing this is using a close operation. So to try to close the borders, and we had quite a lot here. So I put 3 maybe. So sometimes we can see it joins bone, but this case is actually just only helpful. So I fill the model as well, so we get part of it filled, and we don't need it to be completely filled, but if we want to, we can use this local filling or patch tool to fill it, but they will do for now, I think. We could have worked more to get through the temporal bone completely filled, but it's not critical when printing. Okay, so then we can look at it in 3D. So it looks pretty good. So what we can do is maybe now it's time to make a small smoothing. So maybe 0.6. Okay, and apply, and directly can see the result here. Now I want to cut, so we only get the anterior part, the frontal part of the skull. We don't need the other ones to print. So we can click here to see from the right side, and then we can just say I want to cut around here in coronal view. So just click here to mark the point, start the plane, and select that I should keep the cut in the coronal view, and now I want to keep the anterior part and throw away the posterior part. So we get here, and here you can see bones that are cut away, so we can delete those. Only take the largest part. Okay, looks good. Now we want to cut this in the sagittal view. So we can actually look from inside here to help us find the symmetry axis. So I use point tool to add this. Can view it from the other side. And here. And then we want to make a cut in an oblique plane for these points. And we want to keep both right and left part. Okay, so this is our left part. And we want to take away all the small part and non-contiguous. It's only one object. So now we call this left deformed. Here we had the right part. Again, ensure that take all the right part, and there's only one object. Good. So we call right reference. And now we can start deleting some objects we don't need anymore. So we don't need all of these. And now we want to create a mirror of the right reference. So we mirror it in the sagittal view. And then we can simply rename it to reference mirror. So now we have the left part, the deformed part, and then the reference mirror that we can use for bending the plates as Per showed. And they are now ready for printing. So this ends the live demonstration for today. I also emailed out earlier today that the last lecture, we will postpone it for a while to gather some more material for that. So I will keep you updated on email. So there will be no lecture on Friday. But I will keep you posted. For the Swedish audience, I also send out a link for a related event on starting 3D printing facilities on hospitals. And if there are any questions now regarding the course, since most of the course has been finished, just let me know. I will also send out a questionnaire on what parts we should improve and do differently in the future. So with that, I think I would like to end this lecture. And thanks a lot for the interest so far.